Thank you, Professor Chang.
Okay, we are a little bit over time, so I would like to ask all next speakers to stick to the allotted time, because otherwise there will be no discussion, and that will be a pity for everyone. So the next speaker is Professor Jerry Criner, and Professor of Respiratory Medicine in Philadelphia. He will speak about clinical phenotypes of combined heart failure and COPD. The floor is yours.
Great. Thank you very much, and special thanks to Leo for inviting me again to speak here at this conference. It's a real honor to be here. So what Leo had asked me to speak about is this phenotype, combined COPD with combined heart failure, which hopefully over the next 15 minutes I'll be able to convince you it is the king of all phenotypes, because this directly leads to patients' morbidity and mortality with COPD. These are some of my disclosures. So as you well know, over the last 2 decades, there's been protean pulmonary and non-pulmonary manifestations of COPD that have been described: hyperinflation, emphysema, airway predominant, hypercapnia, hypoxemia, and osteoporosis. But of all of these, the most important, actually, are patients with cardiac disease. So what's the basis for that? Well, this is data from the lung health study now over 30 years ago that looks at causes of death in patients who were enrolled into that study approximately 15 years after that. And as you can see on this slide in the orange, after lung cancer and respiratory diseases, the next most common cause of death in patients with COPD was from a cardiovascular source. If you look at the range of cardiac diseases, it's just not ischemic heart disease or congestive heart failure. As you can see in this epidemiologic study by Kirkendale about a decade ago, arrhythmias, angina, acute myocardial infarction, and congestive heart failure are all much higher in the COPD patient population compared to age-matched, gender-matched controls. If you look here in this paper, congestive heart failure was almost 3 times greater than age-matched controls in this study. And besides that, if you look further, when we have trouble trying to discern exactly what the cause of heart failure is, other cardiovascular disease or any cardiovascular hospitalization is at least 2 times greater in the COPD population compared to the control population. Well, if we look at the range of cardiac diseases that we have in COPD, besides heart failure and ischemic heart disease and atrial arrhythmias, it's evolved further that we now know, and I'll show you later, the impact of hyperinflation and what that does on cardiac function, as well as the presence of diastolic dysfunction. And as you well know, and those who take care of patients in this room, patients don't have one of these. Patients can have several of these features that can overlap in any individual patient. So not only is heart failure important in the COPD patient, having heart failure and having a comorbid condition of COPD is very important to the heart failure or cardiac patient. This is data in stable COPD that looks at the high prevalence of COPD and stable congestive heart failure shown on the left side of the graph here. And then this looks at the impact on the right side on this graph, the stages of COPD by gold grade and what that does for survival in patients with congestive heart failure. And as you can see here at gold grade 4, these patients have about a 40% survival at about 3 years in follow-up. 1 year, I can't really see that, but I think it's about 2 years in follow-up overall. So COPD complicating congestive heart failure in a stable state has a marked negative impact on survival. And in this recent paper that was published about 6 months ago in Chest, this looked at the Worcester heart failure study, almost 10,000 subjects, and looked at the impact of COPD on someone who was admitted to the hospital for acute decompensated congestive heart failure. And as you can see with this, the median survival in these patients was 18 months in patients that had COPD with acute decompensated heart failure. Approximately a 20% increase in mortality in patients with heart failure who have COPD. So it plays both ways. If you have COPD and heart failure, your mortality is higher. If you have heart failure and COPD, your mortality is higher. These are linked codependent disorders. Well, why do we have increased heart failure in patients with COPD? This is data from David Menino's group that looked at the ARIS study, atherosclerosis risk and community study, and looked at the impact of COPD by goal grade on patients' risk of cardiovascular event. And as you can see in this curvilinear relationship, if you had a higher goal grade, your likelihood of having a cardiovascular event was approximately 6-fold higher, about 12% if you're in gold grade 4 of having any cardiovascular abnormality. Well, there are several reasons for this in a pathophysiologic standpoint why patients with COPD should have a greater risk of heart disease. It's age, it's smoking, past smoking, current smoking, lung inflammation, systemic inflammation, dynamic hyperinflation, and then substantial other comorbid conditions like diabetes and hypertension and obesity that complicate patients with COPD. This is a putative mechanism for the risk of cardiovascular disease and COPD by McClay in respiratory in 2007, that the high prevalence of smoking and being overweight and diabetic with COPD then leads to increased atherogenesis and decreased fibrinolysis, and that's coupled with the COPD effect, with inflammation in the lung that may spill over into systemic inflammation, and then the combination of these factors leads to muscle wasting, an increased heart rate, and decreases left atrial and left ventricular filling. It may lead to a higher prevalence of congestive heart failure. This looks at the impact of age on the presence of COPD, having patients with cardiac disease. And as you can see in this study by Chen, in over 100,000 individuals, that ischemic heart disease and congestive heart failure is much more prevalent in those who are 60 years of age and greater. In fact, those who are 70 years of age and greater, the prevalence of having ischemic heart disease is approximately 30%. So these diseases, heart disease, is very common in the COPD population. This is one paper that looks at the effect of chronic and then acute smoking and what that does on left ventricular ejection fraction. This was in Chest about a decade ago, and as you can see in healthy smoker 1, those patients who didn't have airflow obstruction but were active smokers, their left ventricular ejection fraction was reduced significantly. And then if patients smoked a cigarette and had an echo done 1 hour later, you can see a further suppression of left ventricular ejection fraction. So current smoking has a chronic effect, but current and active smoking may have an acute effect on cardiovascular function. There's also a clear-cut association between the degree of airflow obstruction and your risk of heart disease, as these papers have shown in almost 50,000 patients that if you're more likely to have airflow obstruction, your risk of cardiovascular disease is much higher. So airflow obstruction is a significant factor. And we well know now that in patients with COPD, vascular stiffness is present. In this paper by Eckhoff and colleagues from Bill McNee's group, you can see that those who had more significant airflow obstruction as measured by the FEV1 had an inverse relationship to flow-mediated dilation or vascular stiffness, and conversely, if they had more evidence of systemic inflammation with a higher CRP, also their degree of vascular stiffness was also much higher. COPD, as we know, has a combination of airflow obstruction and lung and systemic inflammation. This may be a factor that contributes to the increased risk of cardiac events. Here in this paper by David Menino again, looking at the combination of comorbid conditions in patients with COPD, also tracks gold grade. If we look here at the hazard ratio for prediction of death in patients that had gold grade 3 and 4 disease, the likelihood of having comorbid conditions, several comorbid conditions, such as diabetes, hypertension, and cardiovascular disease, was approximately 10-fold greater than patients that were normal or had gold grade 0 disease. One of these papers is most significant and really highlights the clinical confusion that we have in discerning patients who have heart disease and or COPD that presents in the emergency room. Was reported by these colleagues who looked at acute autopsies in patients who presented to the emergency room for a COPD exacerbation, but at autopsy they found different causes for the cause of death other than a COPD exacerbation. They found that 37% of the time these patients had heart failure, 21% of the time they had pulmonary embolism. Disorders that may be related to increased clotting that may occur in a patient with COPD. And these are some reasons why. This is work by Undes and colleagues from thrombosis and hematology that looked at fibrin clots in normal individuals by electron microscopy to the right, where you can see these delicate sort of noodle or spaghetti sort of clusters of fibrin. But look at the patients with COPD here shown to the left. These tighter, more tangled bundles of fibrin that may predispose patients to clot formation. This is some data that we generated by taking about a dozen patients with COPD in a stable state and looking at clotting factors, tissue factor procoagulant shown to the left side, and thrombin antithrombin products shown to the right side. And as you can see, compared to age-matched normal controls, that we found a twofold greater prevalence of clotting abnormalities in patients, or proclivity to clot, in patients with stable COPD compared to age-matched controls. This is data from Wadzika and colleagues that looked at systemic factors of inflammation in patients during a COPD exacerbation compared to stable states both before and after the exacerbation. And as you can see, during the exacerbation states, there were significantly higher levels of fibrinogen and interleukin-6, suggesting systemic inflammation that might be driving the clotting disorder that happens with patients during an exacerbation. Well, this is data that we generated looking at flow-mediated dilation in COPD patients who were admitted to the hospital for an acute exacerbation. And as you can see in the red, these patients with COPD, was 14 patients compared to age-matched normal controls, had a significant increase in vascular stiffness by brachial artery, shown in the acute state. The significant part of that was NO independent. This degree of vascular stiffness is only matched by patients with severe rheumatoid arthritis, and even much more significant than patients who have cardiac disease. Besides these factors, another contributing factor to the development of heart failure in patients with COPD might be diastolic dysfunction, or a stiffened left ventricle. And in this data by Abused and colleagues who looked at patients who were repeatedly admitted to the hospital for COPD exacerbations, you can see here with 2 and 3 times that they were admitted to the hospital, the prevalence of diastolic dysfunction was much higher. Well, we recently completed a study called STACOPE that was published in the New England Journal of Medicine in May of 2014. And in this study, we took patients that were predisposed to an exacerbation but didn't have any risk of heart disease. And because we were using a statin, we had to exclude patients who should have been on statin therapy anyhow. Other than that, they were identical to patients that were enrolled into the NIH macro trial, patients who were at risk for a COPD exacerbation. When we looked at the data compared to both studies, in the macro group that's shown to the left, you see a rate of COPD exacerbations that's about 1.85 events per year. When we looked at the STACOPE population, otherwise identical to the macro, same age, 65% using oxygen therapy, a third GOLD 2, GOLD 3, GOLD 4 stages, we found a 24% reduction in the rate of exacerbations, 1.35 events per year. Well, why would that be? Well, when we looked at this patient group and we looked at patients in the macro trial who were eligible or ineligible for STACOPE, shown in the blue or red lines, compared to the green, which was STACOPE, looking at the event COPD exacerbation event-free survival, we find that the macro groups, their time to event was much shorter than the patients with STACOPE. When we looked at their demographics, what we found that was important is that patients in the macro trial had a significantly greater prevalence of diabetes, hypertension, heart failure, and coronary artery disease. These data highlight, which Leo and others have promoted, that we might not really know in patients with COPD if it's a respiratory event or if it's a cardiorespiratory event. And perhaps we should really consider what our definition of an acute exacerbation in patients with COPD with a high prevalence of coexistent heart failure or heart disease really is. Well, some other reasons why patients with COPD might have heart failure is shown by this data from Chest and colleagues that looked at patients who had severe lung disease from COPD and looked at their right ventricular ejection fraction and also looked at left ventricular ejection fraction by radionuclide angiography. And what they found was a very close correlation between right and left ventricular function. And when the patients underwent lung transplantation, they repeated this data, this study of radionuclide angiography. What you can see from the right side is right ventricular ejection fraction goes up, but also does left ventricular ejection fraction. So one of the other features with COPD which predisposes patients to left ventricular dysfunction is related to the ventricular interdependence that happens with the right ventricle. If the right ventricle is overloaded, it also will affect left ventricular function. Similar to this, data by MRI scanning by Barr and colleagues using the MESA trial, the multi-ethnic study of atherosclerosis, has shown that patients who have emphysema have a significant reduction in left atrial, left ventricular chamber size, and that correlates with a decrease in pulmonary circulation, especially left, the total pulmonary venous area is markedly reduced. That's true in patients who have COPD from airways disease, but it's even more true in patients with COPD who are afflicted by emphysema. They have the most significant reduction in pulmonary venous cross-sectional area. This may lead to a decrease in left atrial filling, which leads to a decrease in left ventricular end diastolic preload, which leads to a left ventricular ejection fraction reduction. Other data by Helgo Magnussen's group, with Watts being the first author, looked at the effect of hyperinflation on left ventricular ejection fraction. And as you can see from this study, there was an indirect relationship between the degree of hyperinflation impairing left ventricular ejection fraction, and they could correlate then that reduction in left ventricular ejection fraction with a decrease in 6-minute walk distance. So cardiac dysfunction in COPD not only has implications for their survival, but has implications for their morbidity and decreased exercise tolerance. Other data that substantiates the strong signal of heart failure impairing survival in patients with COPD is shown by this study by Hoseth and colleagues that looks at the cumulative mortality in patients based on their BNP. And as you can see here in these higher levels of BNP, mortality rate at 2 years in patients with a BNP that's close to 900 is about 75%, suggesting that these patients have a much greater risk of hypertension, of mortality. So what can you do about it? Well, this is data that we had the opportunity to analyze from the CardioMIM study. CardioMIM study was a aggressive monitoring of heart failure and treatment where an implantable device was placed by right heart catheterization in the pulmonary artery. And it could transmit then the data back to a group of cardiovascular investigators that did a prospective randomized controlled trial based on that data of aggressive heart failure management with diuretics and afterload reduction compared to control. And what they showed in that study is a marked improvement in survival in the management of heart failure in patients that had the data managed by this radio-transmitted device from the pulmonary artery compared to those who were not. Well, about 40% of the patients in this study had COPD. So we were interested in looking at what the impact was on treating heart failure in COPD patients on their survival, and especially their respiratory events. And as you can see on the left side of this slide, we found a significant reduction in this group of patients with heart failure and COPD on their heart failure hospitalizations. But more importantly, and germane to this conversation on the right, we found a 60% reduction in the COPD hospitalizations before and after in a group of COPD patients with heart failure that had their heart failure managed, signifying that if we treat heart failure in COPD patients, we improve their total event rate of both COPD and heart failure exacerbations. Well, one of the reasons why we have such a problem with patients managing their heart failure with COPD is the fear of using beta blockers in patients with COPD who have coexistent heart failure. And this is some data by Straszewski and colleagues that looks at this, that approximately 50% lower rate of using beta blockers in COPD patients who have heart failure compared to patients with heart failure who don't have COPD. And this is data that shows why this might be a problem. This is the marked improvement in survival that patients have who receive a beta blocker for heart failure management and even COPD in this study compared to those who do not. Well, we don't have any prospective randomized controlled data on this to date, but there currently is a trial that's beginning in the U.S. in 1,200 patients looking at titrated beta blocker therapy compared to placebo in patients with COPD. So overall, hopefully in the last 15 or 20 minutes, I've been able to describe to you there's a spectrum of cardiac disease in COPD patients that ranges from heart failure to diastolic dysfunction, and a range of risk factors that we see in our COPD patients, from age to severity of airflow obstruction, to gas exchange abnormalities and acute exacerbation. Hopefully, over the next several decades, we'll be able to describe these events in much greater detail, to have more specific therapy to improve the outcome of these patients. Thank you very much.
Thank you very much for also for keeping the time. I think we can allow a very quick question and a very telegraphic answer if there is any question. Leo.
Thank you, Jerry, for doing a very good job in reviewing this issue. This is a very important issue. The first cost of admission for the hospital, the Department of Internal Medicine, is respiratory failure, particularly in Asthma. And most of these people actually do. This morning at breakfast, Disha was asking for state of the art. Now you got the job. I think that you have to review it, particularly the data that you showed. You know, the stat and the macro and on the treatment effect are critical, because this mixed phenotype is the key clinical issue of most admitted patients to the hospital.
Well, Leo, thank you very much, and I think I found a co-author. One of the important things that we don't talk about, because there isn't much data, but I think we're going to try to develop this in the United States, is that if you look at patients that get admitted to the hospital, things don't always work out so well. We start treating them for COPD and then they die. And one of the reasons may be is that we don't know exactly what we're treating when the patient first hits the door. And a lot of the opportunity where we could improve patients' outcome is when they're hospitalized, that we think of heart disease in the COPD patient and vice versa. And then we can work further on trying to figure out what are the best tests to do in this patient population. Maybe when I admit a patient for COPD to the hospital, I should get a troponin besides taking a cardiac history right away. And really look at that and really find out if I'm missing something. And Bill McNee's studies suggest that 15% of the time, patients are missed who have heart disease that come in, and acute myocardial infarction. So appreciate the comment. Helga.
Is another potential co-author.
Okay, yeah, thank you. I'll take more. I'll take as many as I can get. Thank you.
Do you have any idea how the aggressive treatment of COPD improves heart disease?
No, and I actually think that's one of the greatest opportunities, that the people that should be sitting here besides pulmonologists are cardiologists who should be sitting here.
We are also always talking how important COPD is, but the cardiologist asks them what changes if you keep that.
Yeah.
It's very bad not to know this.
It's very bad not to know this. You're correct.
Okay, thank you very much. We go to the next speaker.